I hope my screen is visible to all of you.
Yes, sir.
Yeah. Good evening, everyone. Uh, Already we are running 7 minutes late, so I don't take much time to present my talk on pediatric medication safety and error prevention. Uh, I take this opportunity to thank the officials bureaus of particular conference, that is Sixth International Conference of RS Doctors, and especially Raj, who is Bharat Raj, who is continuously running this program since last 13 days, and all the officials, students, coordinators from different parts of the country. Uh, with due course, we'll try to understand what pediatric medication safety is very important to us and why there is necessary of preventing errors. Let us understand with a very simple motto of understanding medication errors as a part of academic uh, clinical pharmacy uh, part. Whatever I am presenting to you all today is all about whatever the evidences and researches available till now in the national guidelines from all over the globe. So the whole presentation covers whatever the evidences which are available to us and what are the guidelines which are available throughout the world regarding pediatric medication safety as well as error identification and prevention. So what I have done is I have prepared a small handouts of my presentation with only 5 slides. Content. It is a only one-page document. The particular document I shared to Dr. Bharatraj Jain, who will be sharing you this document later of my presentation. So now I request all of you to understand the topic. Wherever you come across any doubts, please keep it in mind. Once my presentation is over, any point of time you can stop me, but it is better you ask me at the last, because as a online it is very difficult to answer questions in between the middle. So let us take why it is very important to have pediatric medication safety. Let us understand when it comes to medication safety, it is all about whether the particular drugs which are using in the population is safe, effective, and as well as cost effective and efficacious one. So usually what we do is whenever we talk about any drug, most of the time we try to understand that whether drug is safe or not. The first and foremost point which we do is we try to understand that drugs which are used in the population are safe, thinking that we use the drugs. And we also know that every drug is toxic. Every drug is chemical and it's toxic. So let us understand in depth regarding the same. What happens is today or tomorrow we need to use a drugs for a population. How well we use it is matters to us. So let us understand. For example, I am using a particular drug for the purpose of any kind of disease. So what you need to understand is you need to understand that the particular drug which is used in the population is going to helpful to us and it is going to treat us. Keeping in this scenario, we use the drugs. That's what many times we define the drug as a molecule which is used to treat, prevent any kind of disease or disorders. So keeping in this mind, we use the drugs. But actually, does these drugs are helping us? So that we need to challenge us, that we need to understand, that we need to think over again and again, so that we must have a safe effectiveness concentration of the drug which should be safe to us. So why it is important medication safety? We know that drugs are not safe. Our especially our all allopathic drugs are chemicals. So those chemicals are toxic in nature. Today or tomorrow they causes it some serious adverse reactions, or it might be a serious adverse event. So keeping in that mind, adults are treated, but what about the pediatrics? When it comes to a term called pediatrics, try to understand the children which are available with us are not small adults. So we know that adults have got a very good PKPD parameters where you can use narrow therapeutic drugs also from a particular range. But the same condition is not in case of children's. Children are not small adults, hence, we should not use the normal dose which is used in adults. Hence, we have different guidelines which are available to us to treat pediatric guidelines. For example, you might be knowing that even in your pharmaceutics first year, You many times try to study that dose calculation for pediatrics. We have Young's formula, Dilling's formula, Cluck's formula. So these formulas are used to just to calculate the drug dose to treat a condition. So hence, it is very, very important to us to understand that children are not small adults. Hence, they have a separate requirement for treating them because they have their unique pharmacokinetic and pharmacodynamic parameters. And when we have a lot of drugs where they have narrow therapeutic index and narrow therapeutic range, so the same drugs cannot be given to the children's or pediatric population. Hence, it is very, very important for us to understand that pediatric medication safety is very important. The second point is many times even in adult treatments or geriatric care, when we do it, we many times we do dosing errors in inpatient department, especially inpatient department, especially that too in many cases in emergency department in ICUs. So what it happens, why it happens is there are multiple parameters which involves whether it's lack of training to the nursing staff or lack of knowledge of the medical staff, negligency, short period of time with heavy workload. There are multiple factors which involves it for a dosing error. So what happens in dosing error is I have some percentage I have given to you all. I showed in my PPT also. Almost you can understand that dosing errors are very, very frequent in pediatric medication treatment, especially the pediatric medication errors. If you count it overall, the most of the research papers suggest that 22 to 70% of drugs causing dosing error. So let us understand once again, in pediatric medication safety, when you want to talk about medications for a pediatric population, try to understand dosing error is the highest error which we come across, not only in India, overall throughout the world. So this 22 to 70% dosing error is not said by Dr. Sanat Kumar Ramgod or nor you. It is all about published in research literatures. The whole globe is talking about this dosing error, which is very, very common in pediatric population, especially when you talk about pediatric medication errors. There are multiple types of errors. You might be knowing it from the starting of prescribing to the transcribing to dispensing to the administration. So wherever you talk about this, especially in case of pediatrics, dosing errors is very high. It almost accounts for 22 to 70%. The third most important parameter why we need to have pediatric medication safety is because 1/3 of pediatric medications which are administered are having error, that is equal or more than one error in 1/3 of the pediatric population. So you just try to calculate now if over 1/3 of pediatric medications which are administered to the patients are causing error means you can count it what will be the prevalence of a medication errors in pediatrics. Then because of this, because of 1/3 pediatric medications which are administered is causing medication error, the WHO has come with a term called medication without harm. So provide a medication, but it should not cause any harm to the patient. So this suggests that it gives us the idea that 50% of reduction in target for preventing the harm means or preventable harm is all about WHO suggests us. What do you mean by this? That shows that the data suggests us that the 50% of population we can save by just doing correct dosing, correct administration, correct prescribing, and correct transcribing policies so that we can prevent a 50% harm. So, for example, if you have 100 patients in a general medicine ward or pediatric ward, take it as a pediatric ward, out of 100 patients admitted in a pediatric ward, 50% of the pediatric babies are getting medication errors. So, if you try to understand as a clinical pharmacist perspective, you can reduce up to 50 patients medication error problem. It means that half of the population which are available in pediatrics patients are admitted to pediatric ICUs are suffering with 50% of errors. So it is us to understand that pediatric medication safety is very, very important, and it has to be understood thoroughly, and it has to be discussed minimized, understood, discussed. Why understood and discussed? If you don't understand, you cannot discuss it. Once you understand, you can easily discuss it. So it is very, very important. Hence, it is very, very important us to understand that medication without harm is very, very important, so that we can able to prevent medication error in, especially in pediatrics. Let us understand what about Indian specific context. What about India? When we look at India, we all know that there are pharmacovigilance program of India. We commonly call it as PVPI. They are available. They started reporting of adverse drug reaction under the banner of Indian Pharmacopoeia Commission, which where they have their own centers called adverse drug reaction monitoring centers. They coordinate throughout the globe, throughout India, in different districts, different colleges, whether it is medical college or pharmacy colleges. They have their own setup of adverse drug reaction monitoring center where we report adverse drug reaction. So what happens is, till today we have a common National Pharmacovigilance Program of India approved centers called adverse drug reaction monitoring centers. So till today we report common adverse drug reactions. But what I personally feel is we should also try to report pediatric ADR. Pediatric adverse drug reaction monitoring is also necessary. Even PVPI is suggesting us to have a very good, thorough report in even pediatric wards also. But we personally, we need to understand that we as clinical pharmacists should also concentrate more on pediatric ICUs, pediatric IPDs, so that we can try to identify more adverse drug reactions regarding a drug which is used in the pediatric population. And the most common pediatric issues which come across in India are antibiotic misuse and dosing errors, as I discussed, and unsafe OTC availability. So this leads to a very big public threat regarding antibiotic policies or antibiotic usage lead to antimicrobial stewardship program. Hence, the government of India, ICMR, started antibiotic stewardship program in most of the medical colleges and Indian hospitals. Why? Because even many times pharmacists dispense the antibiotic to the pediatric population without any prescription. So available of OTC medication lead to a common pediatric issue that led to medication error. So hence what we need to understand is Indian specific context is we need to educate the caretakers also, not only a mother or father, even anybody who is in home, who is in family member, who is readily available to the pediatric population easily in home, or anybody who is providing a medication to the baby. So we should be able to educate them regarding this, and we should integrate the pharmacovigilance in pediatric department. Then only we can able to understand the concept of medication error which led to the adverse reaction. What I want to discuss you all is I wanted to understand you all one basic case scenario which made you to all to think again and again when you post in from your college, when you go to pediatric population or pediatric wards during your hospital internship, or any times when you come across any pediatric patient, you should understand this very simple example. It was a real case where 2-year-old child was prescribed with a simple paracetamol syrup for a fever. And the prescription it was written in by the physician, pediatric consultant, very thoroughly, very well handwriting, suggesting that 5 ml for every 6 hours. So that concentration we have calculated, it was almost about 250 mg for 5 ml. So the doctor has suggested us to give 250 mg for 5 ml for every 6 hours. But what caretaker is misunderstood, he misreads as teaspoon instead of tablespoon. So pediatric child started receiving triple dose of the same 5 ml. So 250 mg become 750 mg for every 6 hours. Later, the patient had a hepatotoxicity. This was a real case which come across in my day-to-day routine practice in the hospital. The same case I am discussing with you all. So because of caretaker misreads a teaspoon as a tablespoon, the triple dose of the 250 mg of paracetamol has consumed on the baby, even though there is no fault from the physician, no fault from the pharmacist, no fault from the child. Still the child is suffering now. Only a dose. Instead of 250 mg, the child consumed 750 mg. For every 6 hour, try to understand, every 6 hour, if you make it 6 into 4 times or 5 times, then you come across entire dosing, 4 times in a day. So what is a learning objective by this case discussion? The learning objective is we should use a metrics, proper metrics which are available in pediatric. Only dosing. When it comes to metric only dosing, it is constant completely by mLs. And we as clinical pharmacists should demonstrate to the uh, patient caretakers regarding how to calculate the exact quantity of the dose. Even now, there are some uh, syringes are available to give a pediatric dosing that I try to demonstrate you in the next slides. So we need to understand that metric dosing is very, very important. We should use only metric dosing when we are providing any syrup, in any syrup, especially any syrup. I'm repeating 3 times because we use most of the time syrups to the pediatrics. So we should educate them both. Next is, do we need to concentrate on this? Why we are focusing on medication, that too especially for pediatric medication safety? Does it necessary, or we have other diseases? Why we are talking about only pediatric population? You might be aware that they are not like us. Yes, many of them say that our country is in youth's hand, like all of you. The pediatric population is also same. If we don't take care of them, it is very difficult to understand the future consequences, especially which they are going to suffer, because they cannot tell you, they cannot complain you regarding their problems. If they want to tell you also, many times it is not easy to understand in medical terms. Hence we need to focus on them. As I said, children are not small adults, and you all know that we have weight based dosing. Based on the weight, based on the body surface area, based on the age, we write prescription to pediatrics. Many times you might be heard about the fact called maturation is very important. We have narrow therapeutic ranges. They increases the risk in pediatric population. And most of the systematic review papers, research papers, they say that a dosing error is very, very high. 1/3 of population, as I discussed, greater than equal to one error in some studies. And if you see as overall, most of them in 1/3 population quarterly are completely potential. Hence, we should have a global perspective. Now, where these errors are occurring uh, in uh, in process of across overall medication use process. For example, whether it is OPD or IPD, when patient is prescribed with some medication, where it is going wrong. When you want to understand that, you should understand that it is happening in all the level. It is happening in prescribing. It is happening in preparation of dose, or during transcribing, during dispensing, during administration, and even during monitoring. So all these parameters are involving in dosing error. For example, in prescribing a wrong dose, mg per kg, or wrong route, wrong frequency, or wrong decimals, even sometimes unit confusion, as I discussed in last case, teaspoon versus ml. This is a major problem during prescribing. So whatever I have mentioned in a red color, like wrong dose, route, frequency, these are all the points which I have taken it from the research original papers which are published. The 0, 4, 14th year all research papers, they suggest that wrong prescribing is very, very high, especially when it comes to the dose. The second one is transcribing. That is transcribing from doctor's sheet to the nursing sheet, or to the prescription to the pharmacist. It is happening in IPD. Then many times what we do preparation of dosages or standard unit dosage forms to the pediatrics. During those dilutions and compounding errors, many times even pharmacists are doing wrong, and many times we are pharmacists are preparing non-standard concentrations to the pediatric population. So that is again causing error. The third one is dispensing. We don't have standard selection or of dosing or dispensing. So labeling error is one of the major error which is coming now. Lack of barcoding at a unit dose in India. We don't prefer barcode dispensing. We dispense many times with the help of only brand names. So we don't have barcode dispensing policies. So hence dispensing error is very high. When it comes to administration, in current measurement devices, we don't have proper medical devices to distribute or dispense correct dose to the pediatric population. And many times what happens in ICU patients, infusion rate error is very high, and many times we don't do a double check of the drug which is administered in IV form in ICUs. So missed double check led to administration error. Last one is monitoring. The monitoring is all about failure to the adjust for weight changes. Many times hepatic and renal function we don't check, still we write it. We many times misuse the therapeutic drug monitoring in pediatric population. Hence, these all leads to major medication errors. And what are the conditions? What are the situations where we have high risk situations? What are high risk populations, especially when it comes to pediatric population? Especially, I don't say pediatrics. Especially, I can say that neonates are very high risk. You might be knowing the definition of neonates that I'm not going to discuss now. Neonates and patients, pediatric patients who are admitted to the intensive care units of the pediatric ICUs are having high risk. They have got tenfold dose ranges within the same unit, and they have frequent weight changes in day-to-day routine medical practice. So hence, it is very, very important to check a patient's weight every time regularly so that the accurate dose has to be prescribed and dispensed and administered. The second one is many times high risk situation is in hospital is emergency departments. What happens in emergency departments is most of the time many patient comes to emergency department with very critical cases, critical conditions. Many times, even because of time pressure for the medical professionals, unable to take a actual correct weight, they may measure incomplete weights. Sometimes they may carry a verbal orders to juniors doctors to just to write provide a medications. During this time, in many times errors are highly possible in emergency department. Now, third very interesting is polypharmacy, where you might be knowing it. What is the definition of polypharmacy? Prescription having more than 3 drugs for a single condition, with children with multiple comorbid conditions, different medical complexity, they are very high risk. Even pediatric patients who are in home care also have got a very high risk of developing pediatric medication errors. Though there are some medications, we commonly call it as high risk medications in pediatrics. Example, concentrated electrolytes, which we use it. Concentrated opioids we use to treat conditions. Type 1 diabetes preparations, type 2 diabetes preparations for pediatrics. Anticoagulants, chemotherapy in pediatrics are all high risk situations. What about community and home? How can we understand this? There are unsupervised exposures we come across day-to-day routine practice. Unintentional pediatric medication poisoning remain a leading cause of injury in many of the country. Among that, most of thousands of patients visit annually for emergency department. So in US, there is something called CPSC guidelines. CPSC is all about Consumer Product Safety Commission. This commission had a report suggesting that in 2022, 98 pediatric poisoning fatalities have come across in each hospital minimum, and injuries remain substantial despite of long-term decline in the CPSC guideline according to 24. What they say is in US they have their own product safety commission. So they do a study. They try to understand how many injury to pediatrics emergency department. So where they come across many times that they try to explain, they try to reduce this, but the number is not declining. So there is a high exposure of pediatric population getting exposed to the medication errors. If it is US, you can just think about India, because in US it is very legal for prescription writing. In India, it is you might be knowing it. In India, anybody can write. Even a term called RMP, they don't no, we don't know where they actually practice. Even they write some allopathic medications, and there are something called compounders. They write prescriptions in villages. You might be knowing some other healthcare professionals. They are not trained in allopathy much. Only because of some experience in hospital, they start prescribing allopathic medications to the public, especially for children. We should consult pediatrician. So that is not available right now. So just think about how product safety is going wrong in India. Especially drug use in India is very versatile. It is used like right and left to most of the patients. So we need to understand, we need to educate ourselves. If you consider in India now, the most common problem is unsafe storage in common. Storage is not at all proper in home. Almost approximately 21% of people in homes, they have got a fridge, but they don't store drugs properly. So unsafe storage is very challenging in India. And most of the emergency department visits, if you see that children's assessing the medications for their own, for example, in home, if you keep some syrup, children are taking directly without consulting their own parents. So only approximately 5% caretakers provide medications, even though they do dosing error. So it is very important us to know that that pediatric populations are completely a separate population where we need to take care of them. So what can be done for this community and a home supervised exposure, where we cannot go as clinical pharmacists or doctors, we cannot visit a home, we cannot understand whether they are taking proper dose or not. The prevention is only possible when we have a child resistant locker in a home or locked storage facility. And when it comes to the dispensing in home proper dose to the pediatrics, if it is in home, we should have metric dosing devices. So many times, if you come across any harmful event, immediately you should have something where we can have access to the antidote, like poison helpline. Access is very important. India, we have Poison Information Center, which is established in AIIMS, New Delhi. They have got their own toll-free number. Anytime you can call them and contact them. They will immediately collect your demographic data from your end, and they start treating you. So now what I am discussing is, till now I discussed about the problems which we are facing. Now let us discuss how well we can avoid this. There are multiple ways to avoid this. There is something called computerized prescribing and decision support. Anything we write it, we should write it in computer prescribing format. That is called compute. There is a system called computerized provider order entry. Anything which is prescribed by the physician has to be prescribed paperless. He has to prescribe in tab, or there are some softwares they should use it. Once they write it, they should write accurately the correct dose, right, and duration and frequency, so that the same is forwarded to the pharmacist, and pharmacist will dispense. So computerized provider order entry will help with the pediatric population, and even for clinical decision support, which leads to reducing medication errors. If you just compare with the paperwork, in paper what happens is many times moderately we come across many errors, but in computerized error or computerized order entry, we don't come across. And we should embed kg only weight capture. You should always think that you give a doses which are range checking from mg per kg per day. Try to remember, this is very important in pediatrics. We prescribe, we dispense, we many times give a patients in mg per kg per body weight. So mg per kg per day is very important. It is an actual dose range checking method in pediatrics. Then we should also try to check what is the patient age and what is the patient renal adjustment to be done for case. So if you want to put a patient for higher antibiotic, you should check the patient's serum creatinine, urea, uric acid. Then you check. For example, if If you want to give a Pepzo for 2.25 gram for pediatric population, you should check the patient serum creat. So just one example I want to discuss to you. Then you should have a standardized order sets and dosing calculators. If you don't have a standardized order sets, like there are charts which are prepared in each pediatric department. What is amikacin dose is 5 mg per kg per day, or paracetamol. Take any drug, they have standard dosing calculation charts that should be understood by everybody, that should be followed by everyone. And if not, many times it is better to use a calculators to calculate dose. Avoid any type of free text orders, even though many times they do it, and due to heavy uh, workload in medical practice. But you should always try to go check once again, check the exact dosing and dispense. The another one is barcoding medication administration and EMR. EMAR is electronic medication order. That I will discuss in next slide also. Barcoding is very, very important during dispensing and during administration, because this both reduces the error. Also potential adverse drug events and adverse drug reactions, and which also saves costs. So it is better to have barcoding medication administration, so that you will not dispense any wrong drug and you will reduce medication error. Then what else we can do is we should scan the patient reports, patient product, and what order at the patient bedside is. So whatever the patient is taking in IPD, all those reports should be scanned. So we should integrate these all together. So another one is actually it is very, very important in ICUs. We have some infusion pumps. So we use infusion pumps in ICUs for a longer period of time to treat a patients for more than 12 hours, 24 hours. What we do is we keep a saline to saline. What we do is we should use smart pumps with auto programming. For example, how many drops per ml we should calculate it. We should set it in pumps. You might be knowing pumps are available. Many pumps are available with multiple brands. So we should use those pumps, and we should initiate auto programming from them. Even if you calculate 6 minutes, 6 drop per minute, you can set for 6 drop per minute in a pump. It will only allow you to go for only 6 drops in your vein. So this is how auto programming can be done. Next one is smart infusion pumps are used, and with the standard concentrations. Especially it is better to implement pediatric drug libraries in each department whenever you visit to pediatrics, or you can prepare among yourself that what are the common pediatric drugs are used in pediatric population. So whether if you have a hard copy or soft copy about those which you have, it is better. And you should whenever you anybody suggested you to prepare a pediatric dosing, you should prepare in a standard dosing format, standard concentrations. As I said, auto programming for a pump is very, very important. And always try to double check for high alert medications, as I discussed in last slide. Safe compounding is also very important. Very big challenge. If you don't compound a medication safely, it may leads to many problems. For example, I can say commonly, if you see that many times we do compounding of medications in cancer chemotherapy only. We use HEPA filters to prepare this. But what happens in pediatric? We usually have to prepare this pediatric dosing also in HEPA filters. That many times most of the hospital they doesn't do it. That may lead to nosocomial infections also. That is very, very important. You should follow the ISMP guidelines. ISMP is all about Institute for Medication Safety Practices. And you can also follow ASHP, that is American Society for Health System Pharmacists. They know that how well to do a sterile compounding. So they have their own guidelines called sterile compounding guidelines that we have to follow. Then the pharmacist should always follow the verification according to CPOE orders. This already I discussed in the last slide. So computerized order entry is very, very important that you should follow. Then unit use always unit dose, and it is better in pediatrics if you use ready to administer formats for pediatric whenever it is feasible. So you should have a standard strength. If patient is having 350 ml, you should provide only 350 ml of syrup only. So that concentration we should prepare it and give it to us. So hence, in abroad, clinical pharmacist in pediatric department has got high recognition. In India, still it is booming now. We don't know when we get it, but pediatrics, when it comes to pediatric, we have a lot of work to be done in India. So it is better you always, whenever you dispense a medication, you try to do a barcode verification, use a gravimetrics, you use IV compounding workflow images. So it is better to us to know that the particular patient is actually receiving a particular compound which is formulated by you. Then, as I discussed, weight-based dosing is very excellent procedure which we follow. We should record the weight in kilograms only, kg only. As I discussed, mg per kg per day is very important. Don't count, don't calculate in pounds. LB is not at all good practice in pediatrics. Eliminate LB units from all screens and labels if you have prepared it to you during your visits. So better always remember in kg per day. So mg per kg per day gives you an exact quantity of dose based on the patient weight. So defining the dosing weight policy for NICU patients, ICU patients, whether it is a birth patient or other current admitted patients, it will give you a very clear picture about dosing requirement. Why we are more concentrating dosing means throughout the India, not only India, throughout the world, the dosing errors are very high in pediatric population. Many times they get a less dose or they may get a more dose. Hence, use mg per kg and calculators and fix up the maximum dosing caps, then design for a growth and organ maturation in a particular patient. We have different measurement devices available to us. As I discussed, metrics only. Metric is all about ml dosing. They provide. Also, we have some orange syringes, but we should avoid always kitchen spoons. For just to understand you, I have given both the images. Kitchen spoons usually you know it, but what we do is many times we pour syrup to the in a kitchen spoon and we try to give to the baby, we give to children. So it is not a routine practice, and we have some oral syringes available in the market. Even we should not use it. Better if you have oral syringes, you should calculate it actual quantity of the dose, then you can use oral syringe. And better you also provide pictorial or pictographic instructions to caretakers or to the nursing staff whenever they are giving any drugs to the pediatric population. And also try to teach them all to the who are nursing staff, who are involved in patients pediatric ward department, so that they should understand that dosing is very one of the common parameter which is available in pediatric practice, and that should be very need of our practice for drug administration. And you can use any language which is available to the patient or caretaker, if it is English or Hindi or Telugu, any language which patient feels to understand your language, feels to you use it and educate them regarding this medical device or measurement devices which are available. Then please do double check many times. Do reconciliation of drugs. Reconciliation is prepare every time, each time new formulation. Independent double check is for every drug is very important. That is very high priority when it comes to high alert medications like opioids, chemo, electrolytes, any other antibiotics. And structured handoffs or medication reconciliation at admission to the transfer to the discharge. Every time you try to do a medication reconciliation and provide you a better care. And better involve clinical pharmacist rounds to from the day of rounds to the discharge teaching. It is very important. We as part of clinical pharmacy, we have medication review process. In medication review, we do three types of review. Actually, the first one is treatment chart review, or we commonly call it as medication chart review. A second one is a clinical review. Third one is identifying and management of adverse reactions. In all these three types of reviews, it is better clinical pharmacist should follow the patient, pediatric patient, from the day of admission to the day of discharge. It has to be done day by day, so that he should see the changes in the prescription in treatment chart review and also he or she should be able to understand what are the clinical progress of the condition, disease status as a clinical review. So this will give you a clear-cut idea about double checks. And as I discussed, it is very, very important us to understand detecting this medication errors. We might be studied this. We also aware that there is a particular uh, organization which work for medication errors is called NCC-MERP, that is National Coordinating Council for Medication Error Reporting and Prevention. Uh, this works so always day to day to understand that, to educate the people. It does many works in terms of only medication error is concerned. They capture near miss drugs, unsafe conditions. What they do is they try to avoid medication errors. Then you should build a team in such a way that internal system has to be audited. You should have your own system to audit whatever the drugs prescribed by the physician, whether they have prescribed correct drug or not, correct dose or not, correct frequency or not, correct duration or not. Then external, many times external agency can audit also, so that you should not have any errors in drug prescribing. You might be heard about NABH accredited hospitals. They do follow this up. What they do is they have clinical pharmacists hired in their hospital. They check this medication error is one of the major guideline in NABH hospitals. So when they come to inspect any hospital, there is a department called clinical pharmacology department where clinical pharmacists working. They try to identify these medication errors in day-to-day routine practice. So once you find some errors, you try to educate the faculties. There are many types of conditions where many times medical practitioners should use during prescribing. They should use only capital letters. They should only write a generic molecule. That too, they should mention the strength. They should mention the duration. They should mention the frequency. So there are and when it comes to nursing staff, they should administer the drugs. They should document it correctly. They should keep us a empty vial so that we should check that, then we should then only they should discard it. There are multiple procedures which are available in NABH hospital that we should do it. In US there is something called medmarks analysis. Medmarks is all about the software which is available in US and UK. What they do is they have inbuilt in their own systems in US and UK. What they do is the clinical pharmacist, anytime he come across any medication error in their hospital rounds, they come back to a department, they add it in medmarks. Once they add it to a medmarks, the message will go to the each prescribing or practicing doctor, telling that this particular patient you have prescribed this medication, you have this error, this medication dose you have written wrong. It will alert the prescriber so that they doesn't do a same mistake in next time. So for this also they do audits. They take a feedback from the nursing staff and clinical pharmacist, and they have feedback dashboards. They keep it always. They talk about dose range overrides. Many times they do a late weight checkup, pump alerts they check, and barcode scanning complaints they come across. So these audits has to be done every time so that they will try to avoid this. And what need to be done now? How do we implement it? I'm at last point of my slide now. It's almost another 10 minutes left, so I will try to go to how do you implement this overall implementation of pediatric error identification or prevention. First one is governance is very, very important. We should have a pediatric medication safety committee in each hospital where clinical pharmacy clinicians, pharmacists, nursing staff, and quality in charges of the hospital should be available. So say they should have a monthly discussion about this. They should have each pediatric unit should discuss this. Second one is we should have a standard formulary in pediatric population along with the drug concentrations, that too in kg only. The policy should be in kg only and metric only during discharge medications. Then we should have a technology like US and all, like barcoding, medication administration, or as I said, computerized order entry or smart pump for automation. IV workflow verification has to be brought to India also. And in India, you might be doing that for every disease. There is education. needed, any condition education is needed. Same like here also, we need to educate all the healthcare professionals regarding high risk scenarios in pediatric department. We need to also educate the caretakers. We should also educate the people who are available in the home regarding patient, regarding the medications. The last one is measurement. The measurement is all about monthly safety bundle. For example, if one clinician has seen 100 patients, out of 100 prescription, how many mistakes he has done, that we have to track it. And also you try to track a serious harms which is happened because of error, medication error to the patient, and try to follow the process day to day and check for reliability. This is one flowchart which EMR does. What they do is, once the medication dashboard entry is done, what they do is, they order entry, it goes to the compounding, from order to the compounding, compounding the dispensing to the infusion in ICU, from infusion to the documenting or reordering. So this flow is available. This we commonly call as closed loop medication administration process. This happens because in any part of drug use, if something is goes wrong, easily we can able to identify it. The second one is, it is fully integrated prescription compounding method, where we use IV medication, especially for the safety and reducing medication error time. Doctor, he prescribe any drug, chemotherapy or any drug, then it goes to the pharmacist. Pharmacist will verify that. Then the third one is all about compounding of drug, and he scan it. He sends this to next level, where barcode scanning is done, gravimetry is done. Then it goes to verification for senior pharmacist. He checked this. Then later it goes to nursing staff, where they administer it. So this is how scanning for patient medication, patient ID, right patient, right drug check, documenting, and as well as administration. So what are the prevention strategies? We can prevent it by COPE, that is computerized physician order entry with dose calculators. We can reduce the error by barcode. We can reduce the error by smart infusion pump. We can reduce the error by preparing standard concentrations and unit dose formularies, and we can really reduce the error by doing double check of high alert medications. What is the call for action for overall today's presentation? We should have policy and we should have practice. When there is standard policy for dose calculation, when there is a standard practice of integrating clinical pharmacists in pediatric ward and discharging and patient counseling, this double P, policy and practice, leads to a good education for caretakers and safe home storage awareness. Then by doing this, you as clinical pharmacists also can do a research, strengthening Indian pediatric medication safety database. Last is collaboration. You should collaborate globally and local initiatives to achieve that WHO's standard protocol of harm reduction goal. And we have some practical checklists to be done. Always try to see prescribing, dispensing, administration, monitoring. Always check for complete weight, indication of the drug, target dose in mg per kg or not, what is the maximum dose, what is the renal and hepatic flags for the particular patient. When it comes to dispensing, unit dose, label with mg or ml, barcode verification is done or not, and try to see that whether caretakers have a leaflet which is attached to the patient or not. In administration, you try to always again do a double check, right patient, right dose, right drug, right route, right time, it all in ML device or not. The last one is monitoring. You try to see the monitoring parameters. You might be seen, you are already aware probably, like if you give a ondansetron with a metronidazole, you have QT prolongation in adults. Like that, there are drug-induced lab investigations you can check. For example, tramadol-induced thrombocytopenia is very common. If you use tramadol in dengue patient, it is contraindicated. So you should set the patient clinical parameters after drug is administered. Document the responses of each drug, including a serious adverse drug reaction to the adverse drug reaction to the adverse drug event. So finally, we as a family and community, we should take action so that we should store for a family. We should store medications away out of the sight of from the children's, and we should use the lockers and keep medicine in original child resistant containers, use a relock caps until it click, So relock it in such a way that you should be only able to open it, not your kid. So you try to use again any poison helpline number which is available to you. Overall take-home message is dosing error are the most frequent pediatric prescribing error. WHO suggests us medication without harm. That barcode should be used. Electronic medication administration records should be used and whatever we use it, we should look at that both are safe and cost effective. Pediatrics are very high potentially to have serious reactions, hence we should take care of them. And there are high injuries, that is pediatric poisoning injuries in home and community preventions is to be done. And these are some references for my today's presentation. Most of them I have taken it from the US and UK. Then thank you. If you have any doubt, I am very happy to answer your questions. Hello, am I audible?
Yes, sir, you're audible, sir.
Yeah, thank you. Let me know if you have any doubts, any questions, anything to be addressed. Please let me know. Shall I stop sharing my screen?
We have received few queries from students, sir. What role
Yeah,
can
please.
in improving pediatric medication safety in both hospital and community setting?
As I discussed in my previous slides, it is all about calculating the exact dose. How whether the particular dose which is prescribed by the physician is in mg per kg per day calculation or not. The second one is especially this is for IPD patients and inpatients. So what happens is usually in inpatient department, standard dose is written. It is available to the most of the time to the nursing staff directly. So nursing staff, they know very well about what drug they are giving it and what dose they are giving it. It is only clinical pharmacist plan is to just to recheck the dose whether they are providing the actual dose which is prescribed by the physician or not. A second very important point which occurs in IPD is most of the time, because of their heavy workload by the nursing staff, they may use a wrong dose for wrong patients. So right drug will not reach actually right patient, so they should do a double check. So that is very very important. The third point in hospital setting is, especially hospital setting where IPD, where clinical pharmacist involving himself, is he should try to see that what are the medications who are high alert medications. If they are high alert medications, he should himself or herself should keep a check on those IP numbers of the patient, name of the patient, where high risk medications are administered to the patients, where there are high chance of developing adverse drug reaction. So high check medications should be kept in mind. So first you check about exact dose, whether it is an mg per kg per day, or you check for dosing, whether it is dosing is done or not. Third one is try to see which patient receiving what medication. Fourth point, whether any high alert medications are available. This is for ICU. When it comes to the home remedy, during counseling, you educate the nursing caretakers regarding how well to be used doses, whether if it is syrup, what dose, if it is tablet, how much tablet, what is the strength, how many duration, how many days, what is the frequency. So, and try to give your phone number. If any times any assistance is required during administration, you can keep us in contact. Keep us in a message, or just give a call, so that we will try to advise you. So that will reduce a lot of medication errors, especially in pediatrics.
Thank you, sir.
Sir, sir, one question regarding the rural areas.
Yes, please.
Sir, what some are there any um, government government initiatives for PV in rural areas? Because mostly uh, the rural areas are largely affected for this pediatric dose errors related.
Sir, you are asking purely for tuberculosis?
Um, no, sir. Some of the ear infections also, because in rural areas they
Yeah.
use some.
No, I got your point. Sir, I got your point. What happens, I will tell you. Government has many policies, but preparing policies and keeping with government, or the policy is not available to all of us, is no use. So instead of planning to have, government has its own policy. Let us, we as clinical pharmacists, should understand where we can practice, where what are the possible areas where we can also contribute to the development of best health. Or we should plan some studies, so that we try to understand that this much pediatric population in urban areas are getting affected by medication error. So hence we should have a policy of implementing clinical pharmacists also in the PSCs, primary health centers. So as of right now, government has doing a wonderful work, but we are not sure that we are a part of healthcare team or not, because we are not judging ourselves what knowledge we have. We are not ready to understand what work we have. We are not well prepared ourselves. So hence, when it is not available with us, it is very difficult to be a part of healthcare team. That's what in India, still after 2008 to till 2025, if you see, clinical pharmacists are not part of any government jobs. Why? Because we are lacking many skills. Knowledge is not uh, uh, up to the mark which they accept us. We have only few clinical training subjects. So it is not available in rural area. So you just keep away, sir. It is not available in urban itself. So urban has got many errors. Now in rural, you have plenty. I to accept that, but as of now, we don't have any rules, any regulations which is given. So it is only possible when we as pharmacists, clinical pharmacists, when we show our work to the government, when we make sure that government create awareness to the government, then only government will decide of implementing policies where clinical pharmacists are part of this.
Sir, can we attribute more this to policy making or to our skill related or capabilities of PharmD?
Sir, I will. Your question is excellent question. I will tell you why. Very good question, sir. No, what I do is actually in my college where I have my own students. We give a project in PharmD fifth year, which is actually appropriate to the current need. So what, for example, how best to be preparing a policy by yourself? You can prepare a policy. Very simple way is, you should do a fifth year project in pediatric population, identifying errors in pediatric prescription in rural area only. You just try to see how many doctors are practicing in rural area, what prescription they are writing, are they according to the NMC guidelines or not. What NMC says, every doctor should write the prescription in tablet form. They should write a generic, but they write brand. And each prescription should have dose, duration, frequency. Does it available or not? Does the written prescription is cost effective or not? You do a study of this. You have 1 year study. You do it, prepare exact results, and present to the government. And absolutely, when something is going wrong with the medications, government will come to support us, no doubt. So we should have authenticated data with us. When data should speak, not we. when we present our data to somebody, that someone should be able to understand that this particular area we have not seen it. This
Yes, sir,
particular
got
area
it.
has got a lot of potency where clinical pharmacists can practice. Hence, this clinical pharmacists are integral part of healthcare, since we can include them. Then only they will come us, sir. Otherwise, policies, we have a lot of policies, but not implemented completely.
Yes, sir, got it, got it.
Yeah,
Thank you, sir. Thank you.
my pleasure. Any other questions, madam?
I think there are no more doubts, sir. Thank you, Dr. Sanat Kumar, sir, for that excellent presentation on pediatric medication safety and error prevention, sir. We greatly appreciate you taking the time to share your expertise and help us better understand this critical area of patient care. Your contributions to scientific research are well known, and it is a privilege to learn from a respected authority like you, sir. Thank you once again for joining with us in the SYCCON Day 16, sir.
Thank you so much for the opportunity, madam. Thank you, Dr. Bharatraj Jain and team of SYCCON 6th International Conference, all the students who are taking their active time to understand and learn. I must appreciate the effort done by Dr. Bharatraj and his team to make sure that students should understand the concept freely. Now we can come across many organizations where they take a charge to understand this. Learning never dies. So what I personally feel is, who all are attended today, 78 members, I personally genuinely understand that you are current students, future leads, and you are here to understand yourself with a better understanding of clinical pharmacy, or real public is concerned. So I hope you have a wonderful day today and a wonderful future. Thank you, Anida.